possible through the generous support of the John A. Hartford Foundation, which works tirelessly to improve care for older adults, and the Cambia Health Foundation, which is dedicated to improving the way people experience health care. Access to the COVID-19 vaccines for older adults is being prioritized across the country due to the vulnerability to more serious illness from the virus among this population. However, for the 2 to 4 million homebound older adults and individuals with disabilities, access is challenging or impossible. These challenges are not well understood, but government agencies are beginning to attend to these challenges as the vaccine supply increases. Many jurisdictions are still challenged in identifying who is homebound, and state and local governments must compile lists from multiple sources. And there are additional complexities with the increased numbers of certified vaccinators and variations in stabilizing the supply of now 3 different vaccines that may be used for home visits. Vaccinating those who are at home, older adults, is made even more challenging because of this crazy quilt of definitions. Vaccination, reimbursement difficulties. We've got an echo. We've got an echo. Have your phones on mute. Have your phones on mute. Have your phones on mute. Oh boy.
Oh, Margie, I think there's a problem with having 2 different ripple effect microphones open at the same time, but I'm not positive.
I'm not sure if that's the case, but it sounds like the echo has stopped.
It's resolved.
Okay, good. I think I'll just start that last little bit again. Vaccinating homebound older adults is made even more challenging because of the crazy quilt of definitions, vaccination policies, reimbursement difficulties, and workforce needs, not to mention cultural and language barriers that must be overcome to vaccinate this population. But state and local health departments across the country, working in partnership with the Aging Network, hospital systems, and other community partners, are turning their attention to this population, and a variety of innovative and practical solutions are emerging. In studying this topic, we are seeing some themes emerge. Over the course of this call series, we expect to touch on each of these themes from various perspectives. We're all learning together at this critical moment in time, and these huddle calls are designed to share just-in-time or just-learned information as broadly as possible. Today's discussion is focused on the work and perspective of the area agencies on aging, the AAAs, many of us call them. I'm very pleased to welcome Amy Gottwals from N4A. She will share observations from the AAAs about current state of practice in delivering homebound vaccines, after which we'll open it up for discussion about your experiences and how this plays out across the country. So with that, I'll turn it over to Amy.
Great, thank you. And thank you for having me either back to this group. I think maybe, I don't know if we were calling them huddles before, but we're always so pleased to be invited by our friends at TIFA, and nice to see some faces and names that we work with in other circles. So pleasure to be here today. You set that up so well as far as what needs to, or where our attention needs to turn, and yet the challenges that we face. So on the next slide, that's not much there. That's the work, you know, that public health's doing, actually putting the shot in the arm. But we don't yet have pictures of our work, but I am here to tell you definitely area agencies on aging and their state and local partners are doing everything they feel they can to support this historic, unprecedented effort by public health to vaccinate our nation, but specifically older adults first, which we know has its own inherent set of challenges, even if the reward will be so great. So on the next slide, this you've covered, and I know, I'm sure this group is intimately familiar with it, even if there's half of us coming at this from a slightly different vantage point and without perhaps the history of public health principles. Some of us are really learning, and never thought I'd be working on vaccines, honestly. But the other half having all that grounding and maybe thinking deeper about aging than they usually do, since this is that first priority population beyond our essential workers. So I just think we context set, right? This is what we're dealing with. So a specific aging network challenge that I'll just point out on the slide, since this is really, I can tell already from the slide shared and knowing who's in this group that we don't have to repeat these, but it has been a challenge for our network given their lack of access to vaccine in most places. I'm going to generalize here. We haven't had time to collect data on this, and some of them are still busy lobbying to make sure that their workers are going to be farther up. There are a couple places where they were able to advocate and were able to get at least direct care workers, but sometimes a broader array of AAA workers prioritized. We weren't asking to be right up there with the docs and nurses, but farther down, along with probably close to where public health workers have needed to be, especially now that we're doing this direct assistance with vaccines. So on the next slide, honestly, I wish I could say we had a lot of foresight and we're really thinking about vaccines at the end of last year. I know your public health certainly was, and preparing. I have to admit that, we were trying to finish up that horrible, hard year. And it was really in January when I went, what are our members going to do about this? How are we going to support our members in this next wave of a pandemic life? And talking with my boss and starting to talk with my members. And honestly, what's so powerful to me in retrospect is that as January 7th or 8th, after that first hard week, when we were all really digging into this year ahead, if you weren't already in it, and looking and I thought, well, look, they're going to end up doing lots. We just know they are. They're going to need to serve the needs of their clients. They're going to do that for the very least their clients, and they're probably going to be called on to do more. We don't really know exactly because we're watching from the outside on what's happening in the public health vaccination space. But let's look at what AAAs do now and think about where we know that they will rush to help, where they will get called on to help, and where they're going to end up with the work whether anyone asked or they volunteered. So we looked at what services they have, and it actually aligned so beautifully. I felt a little dumb that we had to look. I mean, it just took that moment of reflection to say, well, let's see, what do we need to do from our modest aging framework of what it seems we need to do on vaccination, since we're all public health experts now, right, after a year of reading all this. I'm joking, of course. But we knew that they already debunk myths. They already put out good, solid information. They're a trusted resource. They have hotlines, essentially, that take calls from older adults and are specially trained to take older adult calls, to kind of know where they're coming from, what other support they may need, what to do with a person who's not hearing very well on the phone, who's maybe got some cognitive issues going on. We're trained to help in that way. We knew that we've got folks in the AAA who are trained to then go to that next level, not just refer someone to another line, but to actually help them enroll in programs, as is what our normal work would be, right? How to walk through your assessment for programs. What about walking through, 2/3 of our members operate state health insurance assistance programs, which is a long way of saying that they help people enroll in Medicare. And honestly, not much is harder than that. I know the vaccination signups are getting a lot of challenges from folks who aren't used to doing a lot of online activity, but signing up for Medicare is hard. So they've done that. They've kind of had that back and forth and transfer of information. So this appointment stuff, if you've got someone who's got the technology in their AAA office or in their remote work environment, knows how to walk older adults through it, and if they can do it for them, then that's a skill set we had. And we knew also that it wasn't just about getting that appointment, even if that's where everybody's eyes are on that prize. The real prize is getting to the other end of that process, as you all well know. So the supportive services that AAAs either deliver themselves or contract with. That might be case management for their most vulnerable clients who are going to need not just I set up that appointment for Mrs. Smith or Garcia, but to be reminding and setting her up to succeed in that appointment, whether she's getting there with supportive services such as transportation provided by the AAA, or if, as I know your topic now, and rightly so, is to focus on those for whom we may need to call her and remind her we're coming today. With the AAA may play a role in doing some of the outreach so that public health and medical entities are doing vaccination in home, but the AAA is there to handle that social work side of it as well, and letting them know, that all the extra touches that we do to make something age friendly that the rest of people putting shots in arms might not have time to do. So next slide. These are just a few examples. I'm not going to go in deep on them. We have others. But a mix of the previous slide, the part that I guess I neglected to say on the last slide is by the time I'd come up with that list, working with our boss and the little bit we could talk to our members in those early weeks, and went to Congress to say, I think we're going to need some of our own money. We don't want to take anything away from public health, but I think they're going to do this body of work. I swear to you, by the time we kind of had that ask out there and 3 weeks had passed and we got support, and thanks to TIFA for supporting that effort, we had a special ask to add some additional dollars into existing pot of money to recognize for everything that was on my last slide, basically, to be able to have more capacity to take our services and use them in support of this massive public health goal. So all that to say, by the time we did that, I realized they were all doing this, and the evidence was everywhere. And it first came up through the media before we even had time to really get a handle. And so on the next slide, you can see more examples. A lot of these pieces are really about what first was reported in the news. And so basically they did everything that first slide said. They're not all doing everything. There is a healthy variation. It depends on, was their state a slightly more state centralized process with a registration system at the state level? They may play one role there. If it's completely county-based health departments, and their planning and service areas over 5 departments, well, then they're, 5 counties, then they're learning the 5 different ways it works. And they may have some of the challenges, maybe that they have great working relationships in 3 of those counties, public health, and the other 2, they just hadn't worked together for whatever reason. So there's been a lot of scrambling, our members are telling us. So they've done a mix of being assigned things, having a governor's press conference where their toll-free line was put out, and then they realized, oh yes, we're in this, to them going around offering help to any of the entities involved. In New York State, here's an example on the slide from Manhattan, New York City, but I know in Western and upstate New York, completely different scene. The State Association of AAAs, the N4A of New York, they just formed a deal with 1 regional pharmacy chain and the 10 AAAs in that region to have a partnership project with something that wouldn't have happened before. So really, they're very much understanding this as super hyper localized, as many adjectives as you can put in front of local. Local's what they do. So that's how our members are largely responding. Next slide, please. Thank you. So they are doing a lot of that actual help in securing those appointments. They're definitely doing it for their existing clients, and in many other cases where they've been either given this role or they've had help in actually tapping into systems, meaning they're working with whoever that entity is, whether it's a pharmacy chain or the health department. There are many places where then the AAA, there's enough agreement so that I'm not going to say this right because I'm not a public health or systems administrator to know how you do it, but that they have access to some of those appointments and can get their people booked in. So it's a mix of everything from they're just acting like the adult child for an older adult who doesn't have anyone in their life who can make this appointment, and they're getting on the same systems non-professionals would, to they're tapped into the system because they've been allowed to be and are playing a very specific role. So you can see some examples. Sometimes they've been tasked with a certain population. The first example on the slide is from Cook County, Illinois, where they were, I think, smart and really focused on family caregivers. So the AAA had a very specific role in finding, identifying, and helping those people navigate a process. So it's one less thing public health has to worry about. So next slide, please. Thanks. So transportation. You're facing this too. Our systems weren't quite designed to have every older adult we know all be going in a several month period to a lot of the same places. But AAAs are also forming new transportation partnerships, and they're working it out. So one, had used Uber Health, used those private rides for some of their clients before, so they had a relationship. But then it became a challenge in that state of Arizona. There were drive-throughs. And that didn't work with their payment model. So they had to re-up their payment model and say, no, you have to stay with that older adult. You're in that line with them. What do you need to be paid for us to do that? And they brokered a new rate. So they're figuring out as they go, just like all the other amazing advocates and public health workers who are figuring this out. Next slide, please. And I think I'm winding down here. Well, they played other roles. I mean, the rollout at HUD congregate sites, we saw many places where AAAs were, I think, wisely pulled in to provide social services even on site. Some of these older adults are going to need help actually filling out the forms that public health needs them to fill out in order to get the vaccine, or the pharmacy needs them if these were pharmacies who were deployed and in fact let me correct myself. I think this was run through that federal pharmacy program. So the next slide, this slide's probably changing now, and I'm so glad to be a part of this conversation you all are wisely having on in-home vaccinations. When I developed these just a few weeks ago, we were only seeing just a few places. Here's an example of a AAA director trying to be at the forefront. But unless the AAAs, and there are some, are embedded in public health at the local or some of them in the state, but mostly at the local level, they're not as, they didn't know where to start. They knew that their clients were not going to be able to leave their homes, not all of them anyway, maybe some, but in thinking about that, that was a lot of what questions we were getting from our members is when is that going to happen? And you all know the barriers to that even happening, even if we all have the social network to be able to deliver people those. There were other issues that were completely outside of our control on around vaccine and vaccine safety and just the need to get as many people as possible. But please, my message would just be that I know our members really want to do more in this space. I'm starting to think this is going to be the people that we cannot give up. We can't finish this job, even when folks like me are finally our turn. We know there are going to be homebound, isolated people who are not tapped in either through the network or that are still out there that are not going to be able to do this on their own. So what we're concerned about is making sure that maybe when we get, I want it to happen now, I'm not giving up, but the idea that if it's not feasible given the magnitude of this vaccination, then if that has to happen later and we have to go back and find the people we missed and they need the in-home vaccination. So again, I'm not saying we're willing to wait. We want to help. We want to do what we can. We know where these people are, and we think we can help everybody find the ones that maybe we're not serving now through these efforts. And we look forward to doing that work with you all as well. I think there's more that can be done at the physical sites that AAAs have access to in communities and want to be able to help. And the important part to note here, with our friends from John A. Hartford Foundation, is we think those places are age friendly and that it would be a tremendous asset for public health to tap. So I'm going to stop there because I might have run over time, but thanks for letting us share what we're doing. I hope it either mirrors or throws out new information for those of you, because I know you're all doing this too.
Amy, thank you so much. Just a wealth of information and such fabulous advocacy by N4A. It's just lovely to hear it. And if we could just advance a couple slides forward, I want to give folks a chance to ask questions. One more slide, please. So, if you have questions for Amy, or if you, well, we could start with that, but you can see on this slide are some other questions that, we're curious to hear from you about work that's going on in collaboration with the AAAs and the practices that you're seeing, the challenges and so forth. But if you do have a question, feel free to put it into the chat or raise your hand on the next to your image in the participant list, and we'll call on you. So let's hear what's going on where you are. Looking for, I see Megan's hand up.
Yes, I'm going to ask a question. So Amy, thank you so much for being here with us today. One of the challenges that we're hearing from public health departments is identifying the population of people who are challenged to leave their home, who cannot leave their home because of age, frailty, or disability, and just creating the lists of those people. So we know that in some cases the Aging Services Network has those lists, and so I'm wondering, what practices you're aware of. Where is that sharing? Is that happening? Where, how is that happening? And how can public health continue to engage to make sure that nobody is being missed?
Yeah, that is a role many AAAs are playing. I'm thinking of examples in Hawaii. I'm not ever sure I'm going to get the technology right. Sometimes I'm struggling to understand exactly what our members are doing, but they were geomapping, and it was all in partnership with public health. And I don't know where the lines were, but they had worked out what the lines were between them. And the AAA's job was they knew where the people were, and then to cluster them. They could advise where you need, if you're going to do in-home vaccinations, let's do this in that efficient way that you would want. You don't want to be ping-ponging across town. So there was some mechanism where that was what the AAA was doing, is targeting it. And I have another example, I think from Michigan, where they were doing that. So they they did exactly as you said. They knew AAAs would know, if not everybody, at least a really obvious chunk where we do know where they are. And they were doing that sync up. One thing I forgot to say before that I'll just quickly say is, I got an example. We're profiling what our members are doing in our newsletter. And the last one I got was from a Michigan AAA with 4 counties. And they were saying, oh my goodness, if we hadn't already had a partnership with public health and with healthcare entities, we wouldn't be doing what we're doing. But they knew us. And then they still didn't fully know us. We had to say, no, we can do this too. But it was easier. And I think that's one of the challenges right now is that yes, we all need to be forming partnerships, and we are, and that's how COVID has been handled as well as it has. But I also recognize that it's much harder for a AAA to make inroads to say, I can support you, public health, if they didn't already have a dialogue between them. And so I do worry there's some places where, and I completely understand where, if I'm public health, I'm like, yeah, later, do you see I'm working here? So I think, I know that AAA director in Michigan said, thank goodness I had these relationships. It allowed us to be working. They were working on this in January to figure out how it was going to roll out in their corner of Michigan. So I think that's a lesson we all learned, is you got to keep your partnerships up, even if you don't know when you're going to need to do something huge together, or you're going to play a tiny role in something huge. And if you can't find the right person, then you won't have that access. So sorry, long answer, great question. That's just one thing I've heard of. There are other ways. They definitely were getting a healthy amount of jobs that would involve, if public health hotlines, I'm sure I'm not using the right words, but you know what I mean. The call centers, if it was a high maintenance older adult, a high need older adult, they would pass those off to the AAA. So I'm seeing lots of examples where the AAA is the secondary call center. We don't want to take over your role, and we want to make sure we're only seeing those older adults with extra needs. So that was something that's pretty common I'm seeing. I'm sure I could think of other examples, but it's kind of whatever they've worked out locally. There's like there's some similar patterns, but then the nuance changes by locality.
Yep. Yeah, thank you so much. That's kind of what we're hearing, but it's good to hear about that, the geo mapping and the clustering. I think that's really helpful.
For those of you who've been listening to Amy, what questions do you have for Amy, or what would you like to share about what's happening in your neck of the woods with respect to the AAAs and their involvement? Tracy, go ahead. Sorry, tell us where you're from.
Sorry, yes, hi, and I'll show my picture here. I'm Tracy Smith. I'm a physician assistant, and I work with multiple house call practices, one located in California and one located in Pennsylvania. And we're kind of in the midst of trying to get our patients vaccinated. And one of the questions that I had that has come up with our organization, and you kind of touched on it a little bit, was the multi-county situation and how we can get multiple counties to work together, because a lot of house call organizations are multi-county. And for instance, we're working with one AAA, or we actually newly are trying to work with one AAA. But the issue is our actual practice location is in an area that is not in that county. So our actual address is in another county, and it's becoming difficult because the vaccine cannot be supplied and kept in another county for that. So we're trying to work with the AAAs, but it gets down to the question of how AAAs are kind of working together in multiple areas to accommodate getting patients vaccinated in multi-counties.
Certainly. Go ahead.
Yeah, no, please, because I can see exactly why that would happen. I'm just not sure I have a solution to that. Just this has been so hyper local that you do have some statewide coordinated efforts with AAAs, meaning their state association is trying to, as much as they can, try to offer some of that consistency and centralization. But if there's variation on the ground, they've only had so much they can do. And we as a national organization, right? It's sort of what the Biden administration is trying to do now. Let's try to have a centralized, but it's all out there. It's all out there. So I can see how that would be a big challenge, and it may have to.
Yeah, well, we have heard of examples. Forgive me, I don't remember where, but we have heard examples of um, uh, uh, public health at the state level establishing agreements, or some of the local public health agencies at least establishing agreements of partnerships so that their workers could cross county lines when the homes were actually closer to the homes they were visiting in their own county than the, so that they could do, 6 and use up a whole vial before the vial is no longer usable. And we've seen some examples of those kinds of agreements. I'm not sure, though, whether they have involved the AAAs. So that's a very interesting take on that would make that an even richer kind of partnership.
Okay, great. Thank you.
I think we have time for one more comment or question. Jane, go ahead.
I don't want to take up anybody's time if anybody has another question, but I've always wondered, Amy, with Elder Care Locator, that the AAAs manage and staff and all that stuff for the Administration on Community Living. Was that ever a thought about engaging the Elder Care Locator, and are you getting calls about this at all?
Yeah, thank you for that question. Yeah, so for those who don't know, M4A operates on behalf of the Administration for Community Living, the Elder Care Locator, which is the national way to find local aging resources. And as I've mentioned, the AAAs already have their own local lines. Those are fed into a state line. So we operate the national. We have been getting more calls. And now of the COVID calls now, I think was 65% on vaccination, which I'm surprised it's that low. I thought it would be higher, but I think people are understanding you need to call somebody local. So maybe that's surprisingly high given that. And we've definitely seen increased call volume. It's a current challenge because what we're doing now is this is why centralization is so hard right now, right? No one knows exactly what's the best place locally to get these vaccines on any given day. So what we're doing is we're referring first to public health, and then secondly to county health departments, assessing on the phone where people are, saying this is going to be your primary source. If you need these additional services, here is also the information for your AAA, and hoping to heck that the two are aligning, and that because we've advocated for money in the package that passed the House today, we'll be bringing our members resources to follow that. And then maybe more to come on roles that National Hotline can play and support, since we do have that expertise in handling older adults on the phone, not online, although we have an online features as well, but to help with this effort. So anything that you think we can do with the locator to further reach nationwide with services locally, those homebound people, we definitely want to help with that.
I want to thank you, Amy, for sharing such incredible and detailed information. If we could just go to the last slide. Such a rich conversation today. And just to end up looking forward. So for the next several weeks, TIFA will continue to host these 30-minute huddle calls on Wednesdays and Fridays on topics related to enhancing access to the COVID-19 vaccine for people who cannot leave their homes. The next call is on Friday, the 12th of March, and our featured speaker will be Carolyn Bridges from CDC, who will provide an overview of CDC's guidance on this issue. We hope you will join us and continue to spread the word to colleagues as well. I've pasted the links for registering into the chat, so please share, and thank you everyone here for all that you are doing.
Thanks everyone. Thank you so much, Amy. It's good to see you.